Good morning, everyone. If I can ask who is not speaking to please mute yourself. Thank you so much for participating today to our webinar on integrating near miss in maternal and perinatal death surveillance and response on regional approaches from Europe, Latin America, and the Caribbean. This is a webinar hosted by the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. And it's a work by the Department of Maternal, Newborn, Child, Adolescent Health and Ageing in WHO Geneva. So thank you very much. I'm Francesca Palestra, and I will be moderating the webinar for you today. I'm a technical officer from the same department and working closely with all the participants and all the partners on the maternal and perinatal death surveillance and response. We will start our webinar today with the presentation from Oleg Kuzmenko, who is our maternal and newborn health regional advisor from the WHO Regional Office for Europe on near-miss tools and the guidance in the European region. Then we will go to the Latin America and the Caribbean with recommendations for establishing a national surveillance system for extremely severe maternal morbidity in Latin America and the Caribbean, presented by our Bremen de Mucho, Maternal Health Regional Advisor, Latin American Center for Perinatology, and the Pan American Health Organization. And after that, we will dive in a country experience from Colombia, with Grace Alejandra Avila Mellizo, who is the coordinator of Non-Communicable Diseases Surveillance Group, National Institutes for Health Colombia, sharing insights and lessons learned from the practical implementation of MPDSR system in Colombia. And then we will continue with the Q&A and answers. Thank you so much. I will just ask you before giving it to Oleg to please the speakers who are not speaking to mute yourself, and to the participants to notice that you have the possibility of receiving interpretation in English or Spanish. And also to please post your question or comments in the chat during the Q&A and also before, so like this we can be able to share your questions. Thank you so much. Over to you, Oleg.
Thank you, Francesca. Good time of the day, dear colleagues. It's a big honor for me to be here today with you. And let me present you the experience of WHO European region implementation of maternal near-miss case review. Next slide, please. Beyond the numbers, principles and approaches were first introduced in WHO European region in 2004. And two complementary approaches were selected as the most appropriate for the WHO region. Confidential inquiry into maternal deaths at national level and near-miss case reviews at hospital level. So near-miss case review implementation in the European region started in 2006. WHO Europe also developed its first manual to facilitate implementation of near-miss case reviews at country level. Those manuals were revised and updated in 2009, having and gaining more experience than in 2016. And the last is currently in use in WHO Europe, and I will present it later during my presentation. Within the course of an MCR implementation, WHO Euro organized a series of missions to countries to assess implementation of near-miss case reviews and provide recommendations and support for its improvement. Currently, near-miss case reviews implementations in many countries, implemented in many countries of the WHO region. And experience shows that near-miss case reviews is more acceptable for healthcare workers than mortality audits. And near-miss case reviews is usually perceived by staff also as easier to perform than mortality audits. So the quality of near-miss case reviews implementation is quite heterogeneous now among different countries and within the same country. The high heterogeneity within the same country suggests that quality of NEMIS case reviews implementation depends to a large extent from hospital factors, including staff commitment, managerial support, local coordination. Currently, WHO Euro supports countries in their efforts to preventing and mitigating barriers that hamper successful implementation of NEMIS case reviews. Next slide. So let me use example of Uzbekistan to present you WHO support in introduction of NEMIS case reviews. First, the regional Beyond the Numbers workshop was organized in 2004 to encourage a higher level dialogue. And then before starting NEMIS case cycle per se in Uzbekistan, national guidelines on the main obstetrical complications were updated to serve as a reference for case reviews and as a standards of care. Implementation of country level started in 2006 with an introductory workshop aimed to encourage commitment by policymakers and other relevant stakeholders, build national ownership, start preparations of a national action plan, and also a regulatory framework. The introductory workshop was followed by technical workshops in 2007 to build technical capacity in effective use of the new approach and develop action plans for NEMIS case review implementation in each pilot facility. The NEMIS case review cycle was pilot tested in 4 large and medium-sized facilities. And after successful testing and discussions of the lessons learned, it was scaled up in 2008. So WHO Euro supported the country in assessing the quality of NEMIS case review implementation, followed by reinforcement in interventions. Such missions to Uzbekistan were organized in 2015, 2019, and next assessment mission is planned in November 2023. And the experience gained in different countries shows that external technical support should be sustained over time, as maintaining the capacity to review NEMIS cases and assessing and reinforcing the quality of the process can take several years. Of course, the process cannot and should not be done only by international organizations and experts. Next slide, please. Building national capacity is a critical part of the process. Appropriate stakeholders of the country should be identified and involved from the beginning. This usually includes the Ministry of Health, relevant academic institutions, and professional associations. And I would like to highlight also that the involvement of patients associations and consumer groups can also contribute to the process. As you can see on this slide, those activities that were organized by WHO presented in the previous slide were accompanied by activities organized by local institutions and experts, which strengthens the national capacity and build national ownership. By 2015, overwhelming majority of health facilities had trained staff to conduct NEMIS case reviews. Same year, the Ministry of Health of Uzbekistan approved use of NEMIS case review templates and reporting forms, which were translated into local languages, which is also important. Next slide, please. So those mentioned above activities in Uzbekistan resulted in following main achievements: availability of national evidence-based guidelines and clinical standards, formed positive perception of NEMIS case among staff and health authorities, and NEMIS case implementation was supported by relevant national orders, availability of trained staff and interviewers who are not only staff members, but representatives of non-government organizations or local communities, those who women trust too, or those who can speak same local dialogues as women does. In majority of facilities which were visited by WHO representative, we saw that the NEMIS case review meetings is conducted regularly, and local administrations quite supportive to implementation of NEMIS case reviews and committed to address those recommendations that developed by NEMIS case review committees. And NEMIS case review committees members are able to provide smart recommendations, which is important, which is really important. These recommendations should be specific, evidence-based as far as possible, measurable, achievable, realistic, and time-bound. And regular NEMIS case quality assessment visits are in place and conducted mainly by local experts, but of course, from time to time by international experts. Of course, it would be not true to say that all is perfect in the country in implementation of near-miss case review. So the COVID-19 pandemic affected all areas of our life, and the implementation of near-miss case reviews is not an exclusion. Uzbekistan, as well as in many other countries, use of maternal and perinatal audits were partially or completely disrupted. This requires strong and concerted efforts from national and local health authorities, as well as from international organizations for renewing or reinforcing use of clinical audits. And we plan our next assessment mission to Uzbekistan in November 23 to better understand the current situation with implementation and current needs to plan our further activities accordingly. Next slide, please. As I already mentioned, in 2016, WHO Europe published the third edition of the manual conducting maternal near-miss case review cycle at hospital level. The manual is based on previous documents and definitions on the literature and on lessons learned from the field over the time of WHO European region. This manual is currently used in WHO Euro, and I would like to present more details on it to you. Please, next slide. This manual specifically explains how effectively implement the individual near-miss case review. It is designed for hospital staff involved in maternity and newborn health care, program managers and policymakers who are responsible for the quality of maternal and perinatal health care at Ministry of Health level and also at facility level. The manual includes 4 main sections and annexes. The first section of the manual provides general information of WHO vision and quality of care, maternal and newborn health, approaches and guiding principles, aim and principles of maternity, maternal near-miss case and review cycle, and describes possible challenges and key elements of successful implementation. Second section provides step-by-step descriptions of how to introduce the near-miss case review cycle at the country level. This includes how to start at national level, example of consequence of activities, prerequisites and description of preparatory phase, how to pilot implementation, what should be included into quality assessment and dissemination of results, how to scaling up near-miss case reviews, like tentative plans, activities, and quality assurance, and what is the role of overseeing authorities at national and international levels. So the third section provides very detailed description of near-miss case process, including general preparation for each session, frequency of meetings, roles and responsibilities of facilitators and coordinators, case identification and selection, invitation of participants, how to set ground rules and code of conduct, materials required, and how to collect the perspectives of women and family members. And the fourth session provides information on how to ensure the quality of the near-miss case review cycle. This includes reasons for inquiry, reasons for ensuring quality, key elements of successful implementation, possible challenges and solutions, as well as suggestions for assessing and improving the quality of near-miss case cycle. And a lot of practical and useful information, also suggestions and examples of near-miss case review forms, templates, and checklists presented in the shape of annexes. And I would like to say that currently, not only WHO, but also partners working on near-miss case review, like for instance, UNFPA, using this manual in the region, and also those forms and templates from this manual. Dear colleagues, just would like to bring your attention this. For those who are interested, you can download the English version of the manual from the chat, which is, and the manual is already uploaded there. Next slide, please. So, of course, near-miss case review implementation is not an easy process, and you can face different challenges on the way. For instance, lack of commitment from hospital, regional, or national managers and authorities, weak local leaders or coordinators, lack of commitment or full participation of local staff, insufficient knowledge of standards or insufficient methodological skills among local staff, staff shortage and high turnover, difficulties in conducting regular meetings, often because of the staff work overload. Not all staff that involved in management of the case are involved. Quite often roles and responsibilities of midwives and nurses is neglected. So lack of effective monitoring of those recommendations that were developed as a result of the audit sessions. Unfortunately, blaming culture is still present, and in some countries is still widespread. This compromises the overall approach and its effectiveness. And in some countries, we saw situations when different organizations that have in their plans any near miss case review of related activities, instead of building on something which is already exists, proposing their own approaches, templates, reporting forms, and et cetera, which confuses healthcare providers who are already accustomed to using certain forms. And of course, we can face a lot of issues on the way. But the good news that probably all of them are solvable. Next slide, please. So studies prove that facility-based individual maternal near miss case review may be an effective strategy for reducing maternal mortality, especially at high burden countries, and for improving overall quality of care, maternal care, particularly in low and middle income countries. However, the audit of maternal and near miss case reviews, audit also used in high income countries. For instance, in Europe, the United Kingdom and Italy have well-established national systems. Near miss case review is an inexpensive and simple intervention requiring little technology. Studies show that even having a single person appointed to perform the near miss case review may increase feasibility and consequently may lead to some improvements in quality and also outcome. But of course, such approach largely reduces ownership of the process, together with minimizing occasions for discussions and team building among staff. Contrary, involvement of all health providers in the health facility promotes successful implementation, ownership, and sustainability of the process. So it is crucial to pay more attention to patient experience of care. It is strongly recommended to always interview women and their families while reviewing near miss case, and to use their inputs for improving care. And in the future, rather than investing resources in exploring whether a near miss case audit is effective, it will be more interested to explore which characteristics make them effective and sustainable. And concluding, I would like to emphasize that in WHO Euro, we're advocating for parallel implementation of different audits, confidential inquiry into maternal deaths at national level, near miss case reviews at facility level, and perinatal death audits at facility and national levels. So all these approaches are based on the same fundamental principles and are complementary for improving the quality of care and for reducing deaths and complications. So therefore, all of them should be part of the overall MPDSR system. With this, I would like to finish my presentation and thank you very much for your attention. And I would like to give the floor to my colleague from PAHO. Floor is yours, ma'am.
Thank you, Oleg. And thank you, Francesca, for the opportunity to share with all of you our experiences in terms of maternal near miss in the Americas region. Well, good morning, good evening, good night, wherever you are. In this kind of meetings, we are in different times. And let me share our experience. Next, please. Next. Thank you. Well, in 2010, member states of the Americas saw that they would not meet target 5A of the Millennium Development Goal and commissioned PAHO to develop a strategic plan to accelerate the reduction of maternal mortality. In September 2011, PAHO's Directing Council approved the resolution DC 51R12 named Plan of Action for Accelerating the Reduction of Maternal Mortality and Severe Maternal Morbidity. Next, please. That was the first time in our region that we include severe maternal morbidity and special maternal near-miss cases as a first step to advance in terms of the reduction of maternal mortality. Here you can see the front page of two documents. The first one is the plan that was approved unanimously by all member states of the Americas, and it was available in the 4 official languages of the region. And also we developed a standardized monitoring and evaluation tool that was also provided to them. Next, please. In this table that was extracted from the final report presented to PAHO's governing body, we see interesting things. In special, the first relevant fact was that only 11 countries shared that data with PAHO, and of these, Argentina only did so to design the baseline. You can see that we just have data from Argentina in 2010. But another relevant factor was that the data were not very consistent and showed large variations within and between countries. And this was very important and commit the different government to do another step. Next, please. Based on what we have just seen, government of the member states of the America commissioned PAHO to design a system to standardize maternal near-miss surveillance, provide guidance on the development of system for national surveillance of maternal near-miss, taking into account that all countries are at different level of development of their surveillance system. As you can imagine, it's not the same thing country with Chile or Colombia when surveillance is working very good and they have a lot of tools to have good data, and countries like Haiti, when just to have information of maternal mortality, we need to wait 5 years or sometimes more than 5 years to have a DHS, and we can't official data of the country. Other aspect was consult countries regularly, every May, about their maternal near-miss data and situation. Next, please. In order to achieve our goals, we selected and invited a group of regional experts to participate in this process, and also invite colleagues from WHO. Please, next, please. In this picture, probably you can identify colleagues from Geneva. I see Lalesey, Jennifer Croswell, and obviously that was an interagency process. We have the collaboration of colleagues from UNFPA also, and we also invite the countries that have the more experience in the region about the surveillance of maternal near-miss. Well, in this process, we reached some agreements. Next, please. After evaluating the situation in the countries and the different models and definitions used, the core group decided, in accordance with the 2008 WHO definition, to establish that maternal near miss is a term that refers to a woman who almost dies but survives during pregnancy, delivery, or the first 42 days after delivery. But it was also recommended to use the maternal near miss criteria, next please, defined by WHO in the WHO near miss approach of the 2011. However, we also agree that countries that use other broader criteria for the definition of maternal near miss, as Colombia, for example, will maintain their definition, but will report the WHO's criteria in order to ensure compatibility. Here, you can see the three categories of variables: clinical, laboratory, and interventions. Finally, the core group approved a draft version of the document that was sent to the countries to incorporate suggestions. Next, please. Well, from the regional office, we coordinate 2 rounds of virtual consultations in which 27 countries actively participated, and the final version of the document was approved in December 2019, and then was launched into all the region for their use. Next, please. Well, I admit that the document is available in the 4 official languages of the region. Well, we have identified 2 different data collection scenarios. Scenario 1 is prospective, when the institution identifies at least one element of severity during the clinical care of the patient, which defines the case as maternal near miss, based on any of the 3 criteria recommended by WHO in 2011. You remember, clinical aspect, paraclinical, or interventional, paraclinical or laboratory. The case is identified, recorded, and reported in real time. That was the first scenario. In scenario 2, that is retrospective, when the institution identifies maternal near miss cases by screening groups with a high probability of having been a maternal near miss. In these cases, the screening of this kind of clusters will allow confirmation of actual maternal near event. In this case, the information is collected from, for instance, blood bank, surgical theater, laboratory, intensive care unit, etc. In the first scenario, information is collected directly in a form, and at the moment when the team that is given the care notice that the women present one of these variables that characterize the case as maternal near miss. In the scenario 2, potential cases are identified and passed on to a case review system, and finally included in the database that the country has. Next, please. Well, as Oleg have mentioned, in the case of Euro, in our case is similar. Each case of maternal near miss need to pass for the surveillance cycle that regularly is applied in the same way as in the case of maternal perinatal death surveillance and response. Just have few difference, but the idea is the same. Next, please. Well, to contribute to building competencies for better analysis of maternal near-miss cases, we have developed a guideline which includes well-known audit tools and has case study examples to train the people that is perform maternal near-miss case surveillance and response. Unfortunately, this guideline has not yet been officially launched. Well, I have many things to share with you, but I think that this is a first approach that I like to share with you. I need to say that all this effort was possible because the support of the USAID that has collaborated with PAHO in this process. Thank you for your attention. Next, please. Now, I'll be passing the floor for our colleague, Grace Alejandra Avila, from the National Institute of Health from Colombia. Adelante, Grace.
Buen día para todos. Mi nombre es Grace Ávila, hago parte del equipo de vigilancia epidemiológica del Instituto Nacional de Salud de Colombia. Muchas gracias por la invitación. Realmente es un honor para el país y para el instituto presentar esta experiencia de trabajo que hemos realizado frente al tema en el país. En la presentación vamos a revisar un poco cómo desde Colombia trabajamos una vigilancia integrada en salud pública de los eventos en maternidad segura priorizados, como son la morbilidad materna extrema o el NEAR-MIS, la muerte materna, la mortalidad perinatal y neonatal tardía y los defectos congénitos. Siguiente, por favor. En ese contexto, next, please. En ese contexto, debemos revisar un poco cómo sustentamos el proceso de vigilancia en salud pública en el país y debemos hablar del marco normativo que nos permite tener un sistema robusto en el cual a partir de 2016 y con una serie de actualizaciones normativas se crea el sistema de vigilancia en salud pública que además se complementa con una normativa en el marco del Ministerio de Salud y Protección Social sobre todo los programas de prevención y prevención nacionales como el Plan Decenal de Salud Pública y todas las rutas integrales de atención en salud materno-perinatal. Siguiente. El sistema de vigilancia en salud pública en el país, el cual se llama o es llamado Civigila, tiene aproximadamente 16 años en funcionamiento. Siguiente, por favor. En el sistema de vigilancia en salud pública se concentra la información de cerca de 15.000 usuarios, en donde se incluyen todas las instituciones de salud, tanto públicas o privadas, que generan o que atienden cualquier tipo de evento de interés en salud pública, y se encuentran también las secretarías de salud de los niveles subnacionales. Toda la información tiene unos flujos establecidos y se recolecta o se consolida a nivel nacional y se comparte con otras instituciones para finalmente tomar decisiones en salud pública. Next, please. Esta es la página web del Civigila, en donde tenemos básicamente toda la información, gran parte de las salidas de información y las publicaciones que se generan de todos los eventos de interés en salud pública. Entonces, no solo los eventos en maternidad segura, sino todos los más de 106 eventos que se vigilan en el país, de tal forma que podemos hacer una integración de la información, no solo entre los eventos de maternidad segura, muerte materna, morbilidad materna extrema y muerte perinatal, sino que podemos adicionalmente hacer el análisis de información con otros eventos transmisibles en su momento, como se hizo, por ejemplo, con defectos congénitos y el tema de Zika, y más recientemente con monkeypox, que también hicimos un análisis cómo se comportaba en el marco de la vigilancia también en maternidad segura. Next, please. En la línea del tiempo, en la evolución de la vigilancia de la maternidad segura, NETS, nos permite resaltar algunos hitos importantes en el proceso de vigilancia. La vigilancia de la mortalidad materna, la mortalidad perinatal y los defectos congénitos inició en el 2006, mientras que la vigilancia de la morbilidad materna se incluyó en el sistema de vigilancia e inició en el 2012. Inicialmente, la vigilancia de la morbilidad materna extrema se hacía al egreso de las pacientes, cuando se garantizaba que las mujeres habían sobrevivido y podían salir vivas hacia su casa. Sin embargo, en 2015 en el país se hace un cambio en este tema de la notificación y las mujeres o los casos ya no se notifican en el momento en que salen de la institución de salud, sino en el momento en el que se identifican los casos en las instituciones. De esta forma, nos ha permitido generar un sistema de alerta temprana que es notificado de forma inmediata a los aseguradores y a los niveles subnacionales, de forma tal que se puedan tomar acciones inmediatas para prevenir tanto la muerte materna como perinatal y complicaciones que puedan ser prevenibles. Asimismo, NETS hemos trabajado con el Ministerio de Salud y Protección Social para articular las acciones de seguimiento de los casos de la morbilidad materna extrema, de forma tal que las mujeres puedan, después de superar la complicación, tener un seguimiento y un acceso a todos los programas de promoción y prevención para el binomio madre-hijo, tanto la mujer como su hijo. Y a partir del 2012 empezamos un trabajo de análisis integrado de estos eventos de maternidad segura con otras infecciosas que nos permite ir un poco más adelante en la integración de la información de la vigilancia de los eventos. Next, please. Next. Este es un ejemplo de más de los 100 eventos que vigilamos en Colombia. Cada uno tiene un protocolo de vigilancia específico en donde se define muy claramente cuál es la definición de caso, cuáles son los flujos de información y cuáles son las acciones a realizar en cada uno. Y tenemos una ficha de notificación que tiene una información básica para todos los eventos, lo que nos permite hacer ese cruce de información. Y adicionalmente, cada evento particular tiene unas variables adicionales. Entonces, en la ficha de notificación de morbilidad materna extrema están incluidas, entre otras, la definición de los criterios de inclusión que nos definen qué es una morbilidad materna extrema. Next, please. Next. Los objetivos de la vigilancia en salud pública, entonces, están básicamente centrados en hacer una descripción epidemiológica de estos casos, hacer seguimiento a los indicadores y poder establecer algunas condiciones que pueden generar esas complicaciones graves durante la gestación o el parto. Next, please. Y adicionalmente, la morbilidad materna extrema tiene un objetivo que, como ya lo hemos mencionado, para el país es muy clave, y es que se haga una notificación oportuna de estos casos, casi poder tener la información en tiempo real, de forma tal que los aseguradores, Colombia funciona bajo un esquema de aseguramiento en salud, que esos aseguradoras puedan tener la información lo más rápido posible para que se garanticen todas las acciones que la paciente necesita, con el objetivo de prevenir las mortalidades, como ya lo habíamos mencionado. Next, please. Next. Entonces, como ya lo mencionó Bremen en su presentación anterior, en Colombia tenemos una definición de caso que incluye las fallas orgánicas, y adicionalmente tenemos unas relacionadas con enfermedades específicas y algunas relacionadas con el manejo, que en el país priorizamos y es clave poder tenerlas definidas de forma tal que podamos tener una acción más oportuna. Sin embargo, están articuladas completamente con la definición que estableció la Organización Panamericana de la Salud, y podemos, son criterios móviles que al momento de generar indicadores pueden ser perfectamente homologables a lo que tenemos estandarizado en la región. Siguiente. Next, please. Next, please. En este sentido, la morbilidad materna extrema para nosotros nos permite, como ya lo había mencionado, hacer una notificación inmediata y una notificación súper inmediata para algunos criterios que para nosotros son clave, que son la eclampsia severa, la preeclampsia y la hemorragia obstétrica severa. Estas tres enfermedades son las que nos causan en el país la mayor carga de mortalidad materna. En ese sentido, al tener una notificación súper inmediata que nos habla que es en tiempo real, en el momento en que se identifica y se notifica el caso, todos los actores que tienen que ver con la atención tienen la información de la paciente, de forma tal que se pueda hacer una atención oportuna, que es el objetivo en estos casos de morbilidad. Y pues ya posteriormente en el proceso de vigilancia epidemiológica se hacen los ajustes de los casos que se requiera para tener la información completa. Si desafortunadamente la paciente termina falleciendo durante ese proceso de atención, se descarta el caso como morbilidad materna extrema y se notifica como mortalidad materna. Next, please. Este es un poco un ejemplo de las salidas de información que tenemos en el país. En el país generamos reportes de forma semanal, de forma periódica por periodo epidemiológico y tenemos informes semestrales y anuales que están disponibles públicos en la página web para que toda la información sea accesible tanto a los niveles subnacionales como nacionales y profesionales de salud que requieran conocer el comportamiento de la vigilancia de todos los eventos de interés en salud pública. Next, please. Y este es un ejemplo de un poco el análisis que se realiza con la morbilidad materna extrema, un análisis en el tiempo en el cual observamos cómo a partir de 2012 que inicia la vigilancia del evento, vemos un aumento paulatino que nos habla de una estabilización en los sistemas de vigilancia y a partir de 2016 vemos cómo ya la notificación es un poco más estable. A semana epidemiológica 8 de este año tenemos notificados 7.579 casos, pero adicionalmente nos permite también analizar el evento en conjunto con los otros eventos de maternidad segura. Por ejemplo, el índice de letalidad, que nos habla de cuántos casos de morbilidad materna extrema terminaron falleciendo durante su proceso de atención, que para Colombia es una letalidad de 0.8%. Diferente en varias regiones del país, pero esa es el promedio nacional. Y tenemos también el índice de mortalidad perinatal, que nos habla de qué porcentaje de estos casos de morbilidad materna extrema terminaron con una muerte perinatal o neonatal temprana, que es cercana al 3.8 en el nivel nacional. Next, please. Y otro ejemplo del análisis de la información está el análisis que podemos hacer por otras variables de interés, por ejemplo la edad, en el cual hemos identificado en el país que la razón de morbilidad materna extrema más alta se concentra principalmente en las mujeres mayores de 35 años, que es muy similar a lo que nos dice la literatura y muy similar también a cómo se comporta la mortalidad materna. Y principalmente en el país la carga de morbilidad materna extrema está dada por los trastornos hipertensivos en su mayor porcentaje. Next, please. Y un poco dentro de las conclusiones y estos factores que contribuyen al éxito y factores para poder garantizar este proceso de vigilancia integrada. Dentro del estudio de caso que se realizó con la Organización Panamericana de la Salud, se pudo realizar y revisar todo este proceso que les hemos presentado y una de las ventajas que tenemos en el país es esa normativa que nos permite garantizar que todas las instituciones de salud y los niveles subnacionales hacen parte del sistema de vigilancia, está normado y es una obligación en todo el país. Y adicionalmente, en el país, partir de la morbilidad materna extrema nos permite fortalecer esa detección particularmente de las condiciones que conllevan a la muerte, haciendo énfasis en el tema de la vigilancia, cómo tenemos un continuo en la vigilancia de la mortalidad perinatal y también en los defectos congénitos. Y esa vigilancia también está respaldada por un sistema de información robusto que es el CIVIGILA, que nos permite integrar la información de diversas fuentes de información y hacer cruces entre diferentes eventos de interés en salud pública. Next, please. Muchas gracias.
Muchísimas gracias, Grace, por la excelente presentación. Thank you so much, everyone. So now we will go to the questions and answers. I'm just gonna share with you that Oleg Kuzmenko had to leave us, unfortunately, for previous commitments, but I will address to him any specific question you may have, and he will respond via email. So now we can go to questions. So we have one question from for Bremen on how do we measure that countries are moving towards are advancing and are moving towards the maternal near miss surveillance. So how do we measure this? And then we have another question from Colombia that I think they already spoke a lot about this, but if you can maybe do a more precise example on how these near-miss audits in Colombia has led to improvements of care, if you can make maybe an example of an hospital. So can we start with these first two questions and then we go to the rest? Thank you so much.
I'm start or Grace?
You start, Bremen.
Okay, thank you.
Thank you.
Thank you, Francesca. This is an excellent question. Just I mentioned that every May, a consultation is made to the countries to see if they have made progress in data collection and measuring some indicators that are surely known for all of you. For example, the maternal near-miss ratio and another one. This is the first step. It's not easy. Not all the countries share information with you, and not all the countries are at the same level of development. Some countries like Colombia had an excellent national system for the surveillance. Even we use sometimes Colombia as an example to follow, and it's very good to see that next year Peru, following that example, approved the national system for the surveillance of maternal near miss in the country, and that was excellent because the product made by the government of Peru is also excellent. And it's not a fast process, but each year a new country is incorporated in the process. Obviously, there are countries that it's impossible to think advance in terms of maternal near-miss surveillance, since they have problems to measure maternal mortality. But as you know, maternal near-miss happen just at health facilities. So in some cases, this could be an asset to start the surveillance of maternal near-miss, at least in sentinel centers in some health facilities. But finalizing your question, but we have also included an indicator in the regional plan for accelerating the reduction of maternal mortality. This new plan was approved by all the countries of the region, but this is a simple indicator. They need to respond a simple question, that is, you have developed a system. It's not problem, it's a national system or a sentinel system for the surveillance of maternal near-miss. That is the only response that they need to provide us. It's very important, this fact, because has an important political impact when we share this report with the country. Over.
Thank you very much, Bremen.
I'm sorry because my English is not so good.
It's perfect. It's perfect. Thank you so much. So Grace, would you like to respond to any specific, un ejemplo específico de mejora de la calidad de la asistencia que pueda para todos?
Sí, digamos que en ese marco de la vigilancia en salud pública para la morbilidad materna extrema, en algún momento se queda en el uso de los datos. Sin embargo, en Colombia partir de la notificación al ingreso y generar una alerta temprana frente al caso, garantiza un poco que la información esté disponible para los aseguradores y que puedan tomar información o generar acciones oportunas frente a la atención de los casos, que es lo que queremos principalmente con la morbilidad materna extrema, que las gestantes o las mujeres sean atendidas de forma oportuna, en el nivel que requieran y que se garantice toda la atención posible para evitar la morbilidad materna extrema. Entonces, digamos que ese es uno de los puntos que en el país para nosotros es clave, no solo hacer el análisis de la información posterior al evento, sino generar esa alerta temprana con información para la acción.
Muchas gracias. So now we have another question. Do you have suggestions on starting a country-based program? Presumably, this will be built on the existing MPDSR system with base support from the government or WHO. Can national professional groups and civil society organizations with interest join? Are there country examples that you can share? I think that from this presentation, we have a few country examples already that we can share. So we are working in this direction on providing to countries guidance on how to integrate the MPDSR system, the near miss in the MPDSR system. Of course, this varies by context because there are contexts with high mortality and contexts with less mortality, but our idea is to include maternal and perinatal as well together. Also, I wanted also to read another question. We have a question asking if there is any such initiative in other, the sub-Saharan Africa. I know that some countries are going in this direction as well, but I'm not sure if there is any already published document on this. So I can come back to you on this. We have another question in the chat. What recommendations would you give to the ministries of health of the country so they can join this project? Bremen, do you want to answer to this one?
Okay. I think that the first thing, it's not easy to advance in terms of include maternal near miss in the surveillance process. But I think that the first step to reach some success is to advocate in the importance of maternal near miss, because not all the professionals, not all the politicians, not all the people at the government level know the concept of maternal near miss and its relevance. For this reason, it's very important to do webinars, to maintain technical meetings, sharing the concept, not just the definition, also how do you can classify a case, how you the benefits that the work in the surveillance of maternal near miss provokes to the health facility. And something that was not mentioned here today is that maternal near miss is an excellent step in terms of quality of care, especially in terms of safety of the patient. So I think that the first step is advocacy. To advocate, you need to know what is clearly maternal near miss and interact with other key actors in terms of advance. Over.
Thank you very much. Let me see. I see another question. Is there a country that is measuring and monitoring inequalities in near miss? This is like, I don't know, Bremen, if you have any of these cases in your region.
Yes. In Pajo, we have a system that is known as Perinatal Information System that is used in many countries. This system has included in the record a form that collects information in terms of the variables, maternal near miss variables. So in this case, we have a lot of information in this system, and recently we have launched one-click indicators that measure quality and inequities in terms of maternal near miss. As our system has not information in terms of income, we need to use other proxies to define inequalities. For instance, we use level of education as a proxy, knowing that illiteracy women are in worse situation than women that have university studies. And using this kind of proxies, we develop a system in our perinatal information system to obtain inequalities or inequities analysis. This is collected from especially for the country that use the perinatal information system. But a colleague of mine have developed the process to use the formulas to do the calculations. So if a country that use other system and collect some variables, or even better, if they have the information of the income or of the quality of work that the women perform, you can use these formulas to calculate this indicator. Thank you for the question. Over.
Thank you very much. So we are at the end of our webinar. If we can share the slides again, so like this we can have the conclusion. But thank you so much, really, everyone, for being with us today. It was really good to have this conversation, which will be, I think, the initial of many others that we will have on the topic in our series on the webinars on MPDSR. And then I want also to announce that for who will be at the International Maternal and Newborn Health Conference in Cape Town in May, we will have some panels on the maternal and perinatal death surveillance and response. One on strengthening the quality of practice on MPDSR, another one on implementing MPDSR with new solutions and opportunities. Another capacity building session for implementers, and then the launch of the MPDSR Global Report, which will be published this year with some global perspectives from different countries on how success stories on how to implement these at regional level and national level, subnational, and facility. So thank you so much, everyone. Next slide. Thank you so much, everyone, for your participation, and we look forward to connecting with you soon. Bye.